Hello, everyone, and welcome to the Dysphagia Matters podcast. I'm Julia, and with me is Jule.
Hello. We recorded this episode at the German Dysphagia Society conference in Würzburg this year. And despite a few technical difficulties, we really enjoyed the possibility of recording this episode in person.
Yes, and we are very grateful that Dr. Bendix Labeit took the time to talk to us about myositis and dysphagia in this population. Bendix is a neurologist at the University Hospital Düsseldorf, and he's Jule's PhD supervisor.
We talked about myositis, the diagnostic and treatment of dysphagia in people with myositis, and the research that Bendix has been doing in this field.
Hello, and welcome, Bendix, to the Dysphagia Matters podcast.
Thanks for having me. I'm also very excited for this podcast.
To dive right in, could you explain what myositis is and how it affects the body?
So myositis is an inflammatory disease of the muscle tissue, and it's an autoimmune inflammation. So it's not an infectious inflammation, but an autoimmune inflammation of muscle tissue, and it's a systemic disease. It can affect all striated skeletal muscle tissues in the whole body. And it's not a particular disease, but rather a heterogeneous group of different diseases. And sometimes it's also not referred to as myositis, but IIM. I don't know if you've heard this term before. This a little bit more characterizes this heterogeneous different disease groups, and it stands for idiopathic inflammatory myopathy. And I think let's just refer to myositis. It's a little bit shorter and more easy to remember. An autoimmune disease causing inflammation of muscle tissue.
And how does it present clinically? Are there any visible symptoms?
It presents quite differently. As I've mentioned, it's a heterogeneous group of different diseases. So we have basically different diseases that have different clinical presentations. Maybe we just look at the most common forms of myositis, if that's okay with you. I would say we have 5 very important different disease groups. So one disease is dermatomyositis. Dermatomyositis, we have an inflammation of the proximal muscle tissue. So the upper limbs, the proximal upper limbs or the legs, the upper leg muscles are frequently affected. And in addition to the muscle inflammation, we also have an inflammation of the skin. So we have a typical rash. The rash usually presents in the face, but it may also present in other areas of the body, for example, in the head-neck region and on the dorsal side of the fingers. We have this common rash in dermatomyositis. We have inclusion body myositis. I don't know if you've heard of inclusion body myositis. It's very prominent in clinical practice because it's usually the most severe form that is not very well responding to therapy, to immunomodulatory therapy. And in inclusion body myositis, we also have this proximal muscle involvement, but in addition also the distal muscle groups are also involved. So the flexors of the hand, for example, are frequently involved in inclusion body myositis. And the name comes from the characteristic histopathological features. So if we perform a muscle biopsy, we look at the muscle tissue with a microscope, then we see the so-called inclusion bodies or rimmed vacuoles. So characteristic features with the microscope. We don't really see it in clinical everyday life, but histopathological features. And this gives the name to this disease. We have other much rarer forms of myositis. For example, immune necrotizing atrophies. It's usually associated with medications. So it frequently develops as a result of medications. We have the antisynthetase syndrome. This is a form of myositis which usually also manifests in the lungs. So in addition to the muscle involvement, we also have a lung involvement. And this also applies to the so-called overlap myositis forms. So we have other manifestations of myositis that overlap with rheumatological diseases. So other connected tissue involvements, lungs, heart, skin, the joints may be involved. And these are also other so-called overlap myositis. And we have the so-called polymyositis. This is basically an exclusion diagnosis. So if you have myositis, but it's none of the other previously mentioned forms, then you summarize it as polymyositis. And it used to be, or it was recently diagnosed quite often, but nowadays we rather consider it as a very rare manifestation. And the reason is that we are frequently more successful in really making an appropriate other diagnosis. So this classification is also part of debate and changes. 10 years ago, we only had 3 types of myositis. Now we have more types of myositis. We have a lot of antibodies, autoimmune antibodies or autoantibodies that we can investigate, and they also change the classification. So it's an evolving thing. What I tell you now may be different in 5 years.
We'll invite you again in 5 years. So how common are these different subgroups of myositis, and are there maybe specific risk factors of certain populations?
Yes, that's a very important question. So myositis in general is a rather rare disease. We have different prevalence rates, as in most rare diseases. We don't really know exactly how common it is, but it's approximately 20 people of 100,000 people have myositis. So it's a rather rare disease, especially if we compare it to other dysphagia diseases like stroke, Parkinson's disease. And then we have, of course, this further subdivision, which makes the particular diseases even more rare. However, they differ with regards to different patient characteristics, as you've mentioned. So, for example, inclusion body myositis frequently affects older men, so 50 years or older. And men are much more frequently affected by inclusion body myositis compared to women. I think the ratio is approximately 3-1. This is different with dermatomyositis, for example. Here, more women are affected compared to men. And here we sometimes also have younger patient collectives that are affected, even juvenile patients who may be affected with dermatomyositis. For example, this immune necrotizing myositis, here we have people who get it after using specific medications. So medications trigger this autoimmune reaction. So we have some medications that may be important. And this is also a recent development. We have new immune modulatory medications, the so-called checkpoint inhibition medications. I don't know if you've heard of them. They are sometimes used to treat cancer patients, modulating the immune system. And they may cause a side effect. They may also cause myositis. And this is something which is newly evolving. So we don't know so much about it, but another risk factor we have to consider and have to bear in mind. And another thing, cancer may also cause myositis. So we have myositis as so-called paraneoplastic syndrome. So a cancer disease may cause an autoimmune reaction, and as a result, patients have myositis. This is particularly common in dermatomyositis, for example.
So, of course, we're interested in dysphagia. That's why we invited you, of course.
Obviously. I'm as well.
So what would you say, how frequently does dysphagia occur in people with myositis?
This is quite common. So as I've mentioned, I mean, it affects all striated skeletal muscle tissue. And as you know, the whole oropharynx and the proximal part of the esophagus consist of striated skeletal muscle tissue. So the tissue which is typically affected by myositis. So it is a core symptom, a really important core symptom. And it's also actually part of the diagnostic criteria, the so-called Euler criteria. Dysphagia is a diagnostic criterion. So it is really a hallmark symptom. patients are frequently affected. We performed a meta-analysis on this topic, and we pooled several studies that looked at the prevalence of dysphagia and myositis. And as commonly in this area, you get totally different results. So if you pool together all the studies, we have a prevalence of approximately 36%, if I remember correctly. But the problem is, as you've mentioned, we have so many different results within these studies. Some studies report a few percent, others report the majority of patients have dysphagia. So that's the main problem. And it's not only a problem in myositis, but a general problem we frequently face in our field. If you now only look at the high quality studies, so the studies that really used instrumental dysphagia assessment, and the studies that really describe the patient cohort quite well, you get much higher prevalence rates, approximately 80% in these studies. And you asked the difference between the different subgroups. Here we do have differences. Particularly the prevalence is much more frequent in inclusion body myositis. So we have a higher prevalence in inclusion body myositis. Again, if you pool all the studies, I think it's 56% in inclusion body myositis, so higher than 36%. In reality, probably even higher. So dermatomyositis, polymyositis had similar prevalence rates, higher prevalence in inclusion body myositis. And if you look at dysphagia with instrumental assessment, you again get higher prevalence rates.
Yeah, so like you say, it's very similar to other prevalence studies and other, especially neurological diseases, depending on how you measure it, how you define dysphagia, it can vary.
Exactly.
You've already mentioned the systematic review and meta-analysis that you conducted, and it's entitled The Impact of Dysphagia and Myositis. So you've looked at the prevalence, you look at something else, and if so, what did you find?
Yes. So besides prevalence, we also looked at outcome factors. So we looked at, do studies report specific outcomes associated with dysphagia? And it's not very surprising. Of course, we have outcomes that are affected by dysphagia. And also the outcomes are not so surprising. We have the common complications, pneumonia. So dysphagia is also in myositis, as in other diseases, frequently associated with pneumonia. We have dysphagia being associated with malnutrition. And we also have studies that report an association with mortality. Some studies even report dysphagia as the only predictor of premature mortality. So the only or main cause of premature mortality. So earlier death in this patient cohort. So it is a relevant symptom. And we also looked at the mechanisms of dysphagia, the pathophysiology of dysphagia, and the treatment effects. And maybe let's focus on the treatment effects, because this is, I think, the most interesting thing for probably most of your listeners. There are several different therapeutic effects that we have. One major topic is applying dysphagia as a target of the standard immunomodulatory treatments we have available in neurology for myositis. So we have different therapies available, prednisolone, azathioprine, different immunomodulatory treatments, and they all may improve dysphagia. And now this doesn't come from very well-designed studies. So some of the studies are only case reports or case series. They have various evaluation periods. So they're not well-designed studies. But we have many, many different publications that really point to a positive effect with regards to the standard immunomodulatory treatments. So one important aspect is, I think, just apply it as a target when you evaluate your medication.
So you mean when you want to look if the treatment is working, look at the dysphagia, if this is changing or if it's ideally improving?
Yes.
Okay.
Yes, exactly. In managing myositis, you frequently change the medication. For example, you apply prednisolone. This causes side effects. So you try to reduce it. And you reduce it as much as possible. So frequently you reduce it and say, well, is the patient stable? Is the patient stable? And if you don't look at dysphagia, maybe the patient isn't stable at all. You just look at the peripheral muscle involvement. You say, well, he can still walk. Or if I evaluate the peripheral muscle involvement, the proximal muscle strength in clinical evaluation, it seems similar to me, so I can further reduce. And this might actually not be the case. This is a very important topic to just apply it with regards to evaluating your therapy. Apply dysphagia as an important target. It is a very outcome relevant symptom, so it should be applied when evaluating therapy.
So the walking could be just the same, and you could assume that the treatment or the patient is stable, but actually the dysphagia or swallowing function might decline more and more, and you wouldn't realize unless you actually do the diagnostic.
We don't have good data how the general muscle involvement is related to dysphagia. We don't have very good data on this. There are some studies that indicate that there is a close involvement. For example, we have scores that evaluate a peripheral muscle involvement. They just look at the strength in different muscle groups, and they see associations with dysphagia severity in the scores. Some other studies don't see them at all. And my personal experience is that it's not a very high correlation. It may be correlated to some degree, but we frequently see patients that have no peripheral muscle involvement at all, but severe dysphagia. We sometimes see patients that are not very severely affected. They have peripheral muscle involvement, they have paresis, but they can still walk, they can still live their everyday life, but have severe dysphagia. And the other way around, we see patients who are wheelchair bound, who can't walk at all, but who have no dysphagia at all. So there is no good correlation. You can't just assume by the general disease condition how the swallowing function is. You really have to look at swallowing function individually. And the same applies to the therapeutic management. So sometimes you reduce prednisolone and the patient stays stable. You think he or she stays stable, and the peripheral muscle involvement is stable, but dysphagia really declines. And therefore, you really have to apply it as an own therapeutic target. This, by the way, doesn't only apply to myositis, but to other neurological diseases as well, but particularly to immune modulatory treatments, because they are closely monitored usually.
So you said it's really important to focus on dysphagia as an outcome. Does it often appear early in the disease progression, or just during the course of the disease, or later on? And how does it progress then once it appeared?
This is actually quite different from individual patient to patient. No, it does not only occur as a late symptom. We have patients who have dysphagia as initial symptom, sometimes even as only symptom. And this is also another important topic. So if you have someone, for example, if you have a dysphagia outpatient clinic and patients come to your clinic and have dysphagia and no other symptoms, you don't know what the underlying disease is. Myositis may be an underlying disease that you have to consider as differential diagnosis. So it may occur early on in the disease, even as initial symptom, even as only symptom, and it progresses quite heterogeneously. So some patients never have dysphagia during their whole career, I would say, as a myositis patient. Some patients have it early on in the disease. It's very heterogeneous, but it may be there from the beginning on.
Yeah, but I think it's not that well known as a disease that is that highly correlated to dysphagia, and having this in mind when doing a diagnostic and you don't know what the underlying cause might be, it's really helpful to think, okay, let's have a look. And then are there, once you're, for example, doing a FEES, are there specific swallowing patterns that differ depending on the subtype of myositis? Or can you tell just by looking into the larynx?
No, so the subtype is, we don't have good data on this. This is the honest answer, and I don't know. Because, as you've mentioned before, it is a rare disease, so the subtypes are even more rare. We do not have good data on this. And I myself tried to do a retrospective analysis, and I pooled all the myositis patients that I could find at my department. And still, there were too few patients to really statistically validly answer this question. So we don't really know. And my clinical impression is we don't have differences in mechanisms and phenotypes with regards to the different subtypes, but they have similar manifestations.
What would this look like? Do you know that from the data or from your experience?
How the manifestation of dysphagia in myositis typically presents? Yeah, it really depends on which of the muscle groups, the functional muscle groups, are primarily affected. So frequently we have the constrictor muscles that may be affected, and then we have reduced pharyngeal contractility as leading symptom. Then we usually see residue as well in the valleculae, but also in the piriform sinus. In fees, for example, we see a reduced whiteout. This is also an important topic where we do not have good data on this yet, but we know that whiteout may be even missing or severely reduced, and this also correlates with the amount of residue in patients with myositis. So reduced pharyngeal contractility is one problem we have. Then we frequently have an impairment of the upper esophageal sphincter. And here, this usually presents with an opening disorder of the upper esophageal sphincter. So something like cricopharyngeal bar in video fluoroscopy may be seen in myositis. Or in fees, we see prominent residue, particularly in the piriform sinus. This is a very common feature that we see in patients with myositis. But also the oral phase may be affected, also the esophageal phase may be affected, so all the other pathologies as well. Particularly if we see an opening disorder of the upper esophageal sphincter as leading dysphagia mechanism in someone who only presents with dysphagia, we always have to think about myositis. So this is a key finding that we frequently see.
And which assessment techniques would you recommend or are recommended for diagnosing dysphagia in myositis? And are there maybe even specific validated outcome measures that people should use?
I would say we don't have a specific validated outcome parameters, so just the regular assessments that we use from other diseases. I think it's important to really include instrumental assessments, fees or video fluoroscopy. In myositis, as I've mentioned, we have this problem of the proximal esophagus, the opening disorder of the upper esophageal sphincter. So I would argue, I'm a really big fan of fees, yeah? But I would argue there are patients in myositis where you need to include a video fluoroscopy to really capture this as the main pathology, because in fees we see indirect signs, but in video fluoroscopy we can evaluate this opening disorder better compared to fees. And sometimes we even have other esophageal problems in the proximal esophagus. So there are patients where I do fees and video fluoroscopy and also high resolution manometry. These are very important diagnostic modalities to really characterize the problem and then to guide your therapeutic concept.
Okay, let's move on to the treatment approaches.
Yes.
What are the current treatment options available and also the evidence base to them for people with myositis?
Okay, as we've mentioned already, applying it as target for the standard treatments, you ask for the evidence. To be honest, the evidence is low. The studies aren't very good, but there are many, many studies. And for example, in the German guidelines, it's included to apply it as a target. Even in inclusion body myositis, we don't have good immunomodulatory treatments for inclusion body myositis, but there are some studies that show that if you use EVIC therapy, it may improve dysphagia. So it's included in the German guidelines to apply it here. This is the one topic. Another topic is, I've already mentioned myositis as paraneoplastic syndrome. So some patients have a malignant disease, and this causes their myositis. So you have to look for a malignant disease, and then you have to treat the malignant disease. Resection of a tumor, chemotherapy, radiation. All of these treatments may improve symptoms of myositis, and all of these treatments may improve dysphagia. We also have studies that report this. Sometimes only case reports, not very high quality studies, but studies that report this. So this is another important topic, treating a malignant disease if myositis occurs as paraneoplastic syndrome. We have symptomatic treatments that are available. So for example, if we have an opening disorder of the upper esophageal sphincter, we may use interventions minimal invasive interventions or even surgical interventions to reduce this opening disorder. Balloon dilatation of the upper esophageal sphincter is something that I have the most experience with, which really improves symptoms for the patients. Sometimes you usually have to perform it repetitively, but sometimes patients are symptom-free for months. I know one patient who he is symptom-free for years, and also the instrumental assessment improved, which is rare. Usually you have to perform it more frequently. Besides balloon dilatation, we have botulinum toxin injections into the upper esophageal sphincter. Me personally, I don't have a lot of experience with that, but it is also reported to improve hypercontractility. And myotomy is a surgical procedure. Yeah, you basically split the upper esophageal sphincter with surgery. And this is a permanent solution, so it doesn't go back anymore. You really have to be sure that this will help the patient, but you can do it. Me personally, I also don't have a lot of experience with that. I have the most experience with balloon dilatation, and this may really improve symptoms for your patients. Again, you need the instrumental assessment because, as we've mentioned, not all patients have this particularly a problem with the upper esophageal sphincter. If you have someone who has reduced pharyngeal contractility as a main problem, then you do a balloon dilatation and it doesn't improve anything at all. So instrumental assessment is important here as well, but this is a very good approach. So if someone has this problem with the upper esophageal sphincter, we may use interventions here. And of course, speech-language pathology and the behavioral interventions. And here, to be honest, we also don't have very good data what to do. I have some personal experiences, what differentiates people with myositis from other diseases, but we clearly need more studies which investigate this. Yeah.
So I guess dysphagia treatment would also then depend on the symptoms, sign and symptoms that you're observing, for example, during instrumental assessment.
Yes. As always, this is probably also true for myositis. There is one difference, I would say, in people with stroke and Parkinson's disease, for example. We frequently have patients who don't notice their symptoms at all. They have sensory impairment in the pharynx. They have residue and don't notice that residue are there. This, from my experience, is a little bit different in people with myositis, because here it's a primary muscle disease. The sensory system is intact. There are no central lesions that impact sensory, impact coordination, impact the skill of swallowing, but it's basically a muscle problem that we have. So people with myositis frequently notice or more frequently notice their symptoms. Especially they notice residue and they spontaneously compensate by doing additional swallows, by doing piecemeal deglutition. So sometimes you insert your endoscope, the patient swallows 8 times. And sometimes it's effective, sometimes it's not effective, but frequently it is effective. And you can also, of course, implement this within your speech-language pathology to use this to really say, well, try to focus on, do you have residue? What can you do? What is effective to clear residue afterwards? And they are usually not cognitively impaired, the patients, so you can basically apply your therapy approach, make it complex. The patients won't mind. This is really different with regards to other diseases.
Yeah, I think that's really helpful to keep in mind when treating these patients. On a conference, it's always a busy time, so I'm looking at the time. I think maybe very quick question. You've conducted a research study, or you've looked at a diagnostic algorithm for detecting myositis as a cause of unexplained dysphagia. What clinical observations led you to develop this approach? And could you maybe walk us through this very quickly?
Very quickly. Okay. I try my best. So the observation, I can make it short here, was basically, as we've mentioned before, we see patients who have myositis as underlying disease that present with unclear dysphagia at our outpatient clinic. So we have someone who only has dysphagia. We ask ourselves, what is the disease? And eventually we notice, oh, myositis is the disease. So we thought we have to detect it early on in the disease, particularly because we have treatments available. So to make an appropriate diagnosis early, that was the objective. The algorithm starts by characterizing the dysphagia phenotype, because this is the only symptom we have available. So we really have to closely look at how does dysphagia present. We may perform FEES, video fluoroscopy, high-resolution manometry, and look for these particular dysphagia manifestations that are compatible or even indicative of myositis: reduced pharyngeal contractility, opening disorder of the upper esophageal sphincter, reduced laryngeal elevation, and so on. If they are present, as a second step, we performed exclusion diagnostics for other diseases that frequently cause dysphagia. So, for example, we recommend to perform an MRI of the brain, including the brainstem, to look or to exclude stroke, other central lesions. Brainstem stroke, for example, may also cause dysphagia as only manifestation, to exclude these diseases or signs for these diseases. We performed a lumbar puncture to exclude inflammation of the central nervous systems. For example, inflammation of the brain nerves, as in polyneuritis cranialis. We can see signs in the cerebrospinal fluid that hint to this, to exclude signs for an inflammation of the central nervous systems. We performed the so-called FEES-tensilone test. Basically, you look, do you have dysphagia that gets worse when you perform repetitive many swallowing trials, so a fatigue of swallowing, as we see it in myasthenia gravis, because myasthenia gravis is also a frequent diagnosis or a differential diagnosis that may cause dysphagia as only symptom. And if you have fatigue of swallowing, you may apply tensilone, which usually rapidly improves fatigue of swallowing. So this is something we also applied. And we, of course, also performed a very detailed neurological assessment. So clinically, we looked at these patients, even if they don't have any other symptoms, and looked at them carefully, examined them as neurologists love to do it, and looked, do we see signs for other diseases? This was the first step. So exclusion diagnostics of other common diseases causing dysphagia. If there were no signs for other diseases, we continued with the second step. And here we basically performed general assessments that we perform in myositis. So we look at muscle enzymes. They are usually elevated if you have someone with myositis. Interestingly, if you have someone who only presents with dysphagia, they may not be elevated. Why? The swallowing muscles are not very large compared to our other muscles that we have in our body. The legs are much larger, of course, compared to the swallowing muscles, but we looked at muscle enzymes. Are they elevated? We performed a whole body MRI of all muscle groups, because in MRI you may see signs for inflammation. So this is a further step. We performed an EMG. It's an electrophysiological examination. Basically, you put a needle into the muscle, a small needle. It's not very painful. It sounds worse than it actually is. You put small needles into different muscle groups, and here you record the electric activity of the muscle, and here you may see signs for a myopathic impairment. We performed this in our patients, and we performed an antibody panel. As mentioned earlier, we have specific autoantibodies that are associated with myositis. So we looked at different autoantibodies, if they are present or not. And this was the further myositis-focused diagnostic procedures that we performed. And here, if we had further signs for myositis, we continued, or not in all the patients, but we recommended as final diagnostic step, if diagnostic uncertainty remained, we recommended a muscle biopsy, because a muscle biopsy is basically the gold standard to really detect signs for myositis, and also to exclude other forms of myopathic impairment. And here we had two different pathways. If we had abnormalities in the previously investigated muscle groups, in MRI or in EMG, we preferentially biopsied these muscle groups. So for example, if someone had in the muscles of the leg. There was a big edema in MRI. And with our needles, we also measured myopathic impairments here. We would perform a biopsy here in this muscle. But if no other muscle groups showed abnormalities, then we biopsied the clinical affected muscle groups, which were the swallowing muscles, a cricopharyngeal muscle biopsy in the other patients. And this was basically the algorithm where the diagnostic steps that we applied. And with this algorithm, we really succeeded to detect myositis as underlying disease in quite a significant amount of patients. I think we had 72 patients at the beginning, and in 20 patients, we really detected myositis at the end, and of course referred them to an appropriate therapy.
That's very interesting and very extensive. So to wrap it up, what advice would you give to clinicians who may encounter people with unexplained dysphagia or where the myositis is already diagnosed and present with dysphagia?
So if someone presents with unexplained dysphagia, I think the most important advice is to really try to make an appropriate diagnosis and to not give up easily at the beginning, because it is very difficult. We have so many different diseases that may cause a dysphagia. So it's a very complicated stepwise diagnostic approach that you have to apply. And here it's important to not give up. I mean, sometimes you have to give up because you perform all sorts of diagnostics and you still don't know what the etiology or the cause of dysphagia is. I've also experienced these patients, but especially at the beginning, don't give up and try to find it out. And here, I think it's very important to that physicians and speech-language pathologists work closely together, because I mean, I am a physician, but frequently physicians are not so experienced with dysphagia. And it's usually the speech-language pathologist who says, okay, this is not normal. I know this is not normal. And sometimes physicians may say, well, but the patient is rather old. He's 60 years old. Can't it be normal? And the speech-language pathologist is the one to really say, okay, I know this is not normal. This is a very severe dysphagia. And then you really have to work together with a physician. At least that's my experience, because usually it's the physician who really has to initiate all these steps, who has to perform a muscle biopsy. And so you really have to work together. And for a physician, it's very important to listen to the dysphagia findings that are presented to him or her and to really try to understand them and be open-minded about it. And for speech-language pathologists, I think it's important to really get in contact with the physician. And I think this is the most important thing to overcome this hurdle in making the appropriate diagnosis, to really work together.
Yeah, excellent. Thank you so much, Bendix, for taking the time and for shedding light on this important disease, which probably oftentimes is underdiagnosed, underrecognized. Thank you so much, and we hope you enjoy the rest of the conference.
I will for sure. Thanks as well. I was really glad to be here today.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.